So I welcome you all to this first series of Ziauddin Orthopedic webinar series. And we are lucky to have Professor Kyle Dickson with us. And he is very kind to spend his time. He is on vacations nowadays, but still on our request, he is kind enough to join us. So we will start our program. First presenter would be Professor Nadeem Baloch, and he's going to talk about the classification of acetabular fractures.
Good morning and very early good morning to Professor Carl Dickson. I'll give you a brief talk about the classification of acetabular fractures. As we all know, this work was pioneered by these great surgeons in 1964, Robert Ziauddin, Jean Ziauddin, and Amélie de Tournelle. First described the mechanism of and classification and treatment of acetabular fracture. Later on in 1980, Letournel described the latest classification, which is divided into 5 elementary and 5 associated types. Ziauddin initially described it 2 elementary and 3 associated factors. As we all know, the anatomy is conceptualized by 6 structures that are supporting the acetabulum, the anterior column, the anterior wall, the posterior column, the posterior wall, the acetabular dome or the tectum, and the medial wall. They provide almost 170 degrees of femoral head coverage. It was also conceptualized by Ziauddin and Letournel that the acetabulum is in a shape of inverted Y or a lambda. The long anterior limb was considered as the anterior column and the shorter one was the posterior column. And the acetabulum itself is a hemispherical socket, so it's an inverted horseshoe-shaped articular surface and a non-articulating corticoid surface. Then the supports are the sciatic buttress, which joins with the sacroiliac joint, provides the stability, and the quadrilateral flexion. So knowing about this much of the anatomy will help us to know understand the classification and subsequently the management. Again, the anterior column, also known as the iliopubic component, the one in the violet shade, this whole area is the anterior column, and the orangish one is the posterior column, also in the ilioischial component, extends from the superior gluteal notch and up till the ischial tuberosity. So the 5 basic types in simple fractures are the fractures of posterior wall, the posterior column, the anterior wall, the anterior column, transverse fractures. The associated fractures are the T-shaped fractures, fractures of the posterior wall and column, transverse plus posterior wall, and anterior fracture plus hemi-transverse posterior fracture and both column fractures. Again, pictures the description of the anterior and posterior columns. After the classification, I told you there are 5 elementary and 5 associated. The posterior wall will usually involve the posterior part of the acetabulum, but will not involve the sciatic notch. And if it's involving the sciatic notch going all the way through the acetabulum, then it's posterior column. This is the differentiation between the posterior wall and the posterior column. Again, if it's involving the ilium extending up till the acetabulum, but not going through the posterior compartment, then it's an anterior wall. If it's involving all 3 structures, it's an anterior column. if it's going through the acetabulum, it's a transverse fracture. Then there is subdivision of the transverse fracture. As I told you, the very part of the dome is known as the tectum. So if it's lying below the tectum, it's an infratectal fracture. If it's lying just besides the tectum, it's a juxtafractal fracture. And if it's involving the tectum, it's the transtectal fracture. The associated fractures, as I told you, they involve the posterior wall and column. See the wall and the column, the transverse and the posterior wall. The anterior wall and the hemitransverse. It's sort of a T-shape. This is the proper T-shape. And the bicolumnar fracture. It's about full length of the posterior column and the full length of the anterior column. Then there is also a description given by the OTA, although it's good for research purposes, but the standard used now is the Julie and the Litour. So I've just mentioned them. You can just go through. It's typically is a partial articular fracture. And one column is involved. The posterior wall fracture is A1, posterior column fracture A2, anterior wall or column is A2. Again, type B is partial articular fractures, transverse T-type, involving both columns can be B1 is transverse, B2 is T-shape, and B3 is anterior column plus posterior. C is basically complete articular fracture. These are all the both columns, also known as the floating acetabulum. T1 with both column fractures, with high variety of anterior column. C2 is again both column with low variety, and C3 is all. This is a very busy slide, but I'll just mention as before. This is the Otg classification, again showing you the acetabulum partial articular one column, then B partial articular transverse, then C partial articular in both columns. Okay, a study done by Ziauddin and Gagier was done by in late 90s, and they described the frequency of these fractures. So their studies were comparative, and they showed that the most common fractures were the posterior wall, around 23.6%, and both columns was around 21%. Transverse and posterior wall were around 17.4%. So all of them are the commonest ones. Then the lesser common are T-shaped, transverse, posterior column and posterior wall, anterior column and anterior wall and anterior column. And the lowest frequency was anterior column, posterior column, and posterior wall. So this is just the brief description of the percentage that we see in acetabulum fracture. And as we all know, the head of the femur dictates the type of fracture and the magnitude of injury, and the magnitude of force created by the head will give you the pattern of the fracture. So the standard X-ray that we need for this classification is standard APU, 45 degrees obturator oblique view, 45 degrees iliac oblique view, and CT scans, and even volume rendering CT scans. This is a anatomy, we all know, iliopectineal line, ilioscale line, the teardrop, the roof of the acetabulum, the edge of the anterior lip, and the edge of the posterior lip. In the obturator oblique view, you can see the obturator foramen, and it's best for the anterior column and posterior lip or wall fracture of the acetabulum. In the iliac oblique view, this is you can see the iliac wing in its largest dimension, and we can see whole of the posterior column. CT scan provides additional information regarding the size, position of the column fractures, its impact on the acetabular wall, the retained bony fragments, and the degree of combination and sacroiliac disruption. So this tells us about the type and the planning of surgery. Three-dimensional reconstruction allows for digital subtraction of formation of the acetabular surface. This is what I'm going to show in my later slides. This is how a wall CT can be seen. This is how columns. These are 3D reconstructive CT scans, which gives better understanding of the fracture patterns, planning of the surgery, and ability to subtract the unwanted structures. So we just a brief algorithm. We find an acetabular fracture if the obturator ring is intact and the fracture line is extending into the iliac vein. And if it's involving D wing, it's a both columnar fracture. But if it's not involving, then it's a T-shaped fracture. Again, if the obturator ring is not disrupted, the ilioischial and the iliopectoral line are disrupted, yes, if the posterior wall is fractured, it's a transverse posterior wall. If the posterior wall is intact, it's a transverse fracture. Again, if the ilioischial and iliopectoral lines are not disrupted, it's a posterior wall fracture. And it is an isolated posterior wall fracture. So these are the images that I told you, the volume rendering, the subtraction images. We see a posterior dislocation of it, which is incongruent. Once the femoral head has been removed, we find that there is fracture inside the acetabulum, along with small pieces, fragments, which are not letting it do the congruent relocation. This is a posterior common fracture. Again, the disruption of the greater sciatic notch, as we all see. The ischiopubic notch and the ischiopubic ramus differentiate this fracture from a posterior wall fracture. Note the separation of the posterior and entire posterior column. Again, the femoral head has been subtracted and we can see the fracture from all the dimensions. Then the anterior wall fracture. Note the trapezoidal fracture fragment which is lying anteriorly. This one. And without disrupting the ischiopubic notch. Also seen are pelvic fractures at the superior pubic root and the ischiopubic ramus. Usually they are due to lateral compression. This is an anterior wall fracture with very low anterior column fracture, involving the anterior wall and the low anterior column. This is the colored version of the same thing, very low anterior wall fracture. Okay, these are high anterior column fractures. Note the superior extent of the fracture is higher than the anterior superior spine. So this is the anterior superior spine. The fracture goes all the way through the iliac vein, extending into the acetabulum and going all along the anterior. Now these are the infratectum. There's a tectum and the fracture is running all the way through the acetabulum. These are juxtatectum, just below this along with the tectum. This is the transverse tectum. You can see it from the medial side also. So this gives us a really good information about the fracture and its fixation. The infratectal T-shaped fracture, you see the T over here, and also from the medial side. This is juxtatectal anterior T-shaped fracture. This is juxtatectal and extended like a T. This is again the associated fractures. Transtectal anterior T-shaped fracture. Now this is highly comminuted posterior wall and posterior column fractures. This is atypical. Posterior column is atypical as its inferior extends through the ischial tuberosity rather than the ischiopubic ramus. Now this is transtectal and atypical posterior column or massive posterior wall extending all the way to the greater sciatic notch. Then comes the transtectal transverse and the comminuted posterior superior fracture. Again, After subtracting the femoral head, you can see the geometry of the fracture, the fracture fragments, and also from the medial side, how comminuted fracture this is. Then there is anterior wall plus posterior hemitransverse fracture. You can see the medial displays inferiorly hinged quadrilateral plate. This common association with high energy anterior wall. Told you again that anterior column can be low anterior column along with the posterior hemitransverse fractures. The anterior fracture in this case is the low anterior type, and the posterior hemitransverse fracture does not separate the posterior roof from the sciatic fracture. This is bicolumnar, highly comminuted fracture, and as a result, the sciatic buttress ends as a spur, usually spur. This is bicolumnar fracture. The anterior column subtag is lying between the anterosubiliac spine and the anterior iliac spine. Posterior column component of the fracture is atypical, ear extend in the ischial tuberosity. Again, the sciatic buttress is separated from it. Then the posterior superior fracture, you see it's involving the roof of the acetabulum. The posterior inferior fracture, transrectal D-type, you see the whole of the posterior column is separated. This is extended posterior wall and transrectal. You can see the degree of combination. The femoral head is the massive posterior wall and transrectal fractures. Single large posterior fragment that includes the posterior roof of the. Okay. This was the description about the fractures. Usually these fractures heal in about a year or so, and the outcome of the treatment may vary from patient to patient depending on the pattern and severity of the fracture, the associated injuries, the patient's age and bone quality, general health of the patient, smokers. Due to the serious nature of vestibular fractures as well as the likelihood of developing long-term complications, many patients are not or will not be able to return to the normal